All right. Well, good afternoon, everyone. Thanks for taking time today on your busy schedule. It's a Wednesday, a pretty day. Thanks for taking time. And on this Facebook Live, I'm going to be honest, it's my first one, so bear with me. My name is Dr. Sonali Lal. I'm a board certified sports medicine doctor in New York City. I'm also the medical director at Integrative Spine and Sports. We have 2 locations in Manhattan, one on the east side and one on the west side. I've been in private practice for 15 years, and I'm a professor at Columbia University for the last 10. So let's go forward. And so just a quick thing on what I do. So has an injury ever gotten in your way? Has pain ever impacted the quality of your life? So every day I see patients that say yes to these questions. My real job is to help them get better. My role really is to diagnose. And I think that's one thing that a lot of times people have knee pain and, they just go to physical therapy for a couple months and then don't really see the results what they wanted to, and end up at an orthopedic surgeon's office, and next thing you know they're having surgery. And my job is to tell you that there's so many other options in between, from getting physical therapy to being on the operating room or being in the operating room. There's a whole gamut of other stuff that we have. So I'm going to talk to you a little bit about that today. And I'm also going to talk to you a little bit about my patient, Desiree. So Desiree is a dear patient of mine. She's 62. She came in to me with severe knee pain. Her knee pain was really impacting her life. She was unable to go up and down stairs without pain. She lives in a 2-story house and was always holding the handrails. She had to go back to work, and she had trouble negotiating steps in the subway, couldn't play with her grandkids, couldn't go for walks with her friends, started, not being able to exercise, gaining weight, getting depressed. And so we're going to just talk about some non-surgical options we did with her as we progress. So let's go further. So let's just talk about some common areas of knee pain. So most of the time, knee pain, there's 2 times where we see our knees get. When we're young, we're playing, we're very active, tennis, football, all that stuff. And when we get older and our knees are sort of wearing down. So the most common one that we obviously see is osteoarthritis. That's the most common form of arthritis in the knee. It's degenerating. It's usually wear and tear. There is a large family history that is involved in it. Also, weight. 1 pound on our on our abdomen is equivalent to 14 pounds on our knee. So if you take the surface area of your abdomen and put it into the small area of really what a knee joint is. So 1 pound is equivalent to 16 pounds on your knee. So if you lose 1 pound, you are actually taking 16 pounds off of your knee. So weight loss is a huge, important thing for osteoarthritis, as well as strengthening of your knees and your quads. But let's talk about some other what happens in osteoarthritis. So when we're younger, we see stage 1. See, this white stuff is the cartilage, the blue stuff is the meniscus, and these pink things right here are the ligaments, right? So here we have the medial collateral, lateral collateral, and ACL and PCL. So when we're younger, or this is really, my opinion, this is a nice thing in grade 1. We don't really see any cartilage loss. As we're getting a little bit older, this is probably the type 2 is more likely in our mid 40s to late 40s. You can see a little bit of cartilage loss, and now here in our 50s and 60s, we kind of get to grade 3, moderate, where we have more cartilage loss, some more degeneration. You can see these little bumps things when we're seeing some bony protrusions coming, and that's where we get more of that bone-on-bone pain. And then number 4 is severe cartilage loss, and usually we can't always salvage the grade 4 with regenerative medicine. Oftentimes this is where we require surgery, but the 2 and the 3 are perfect candidates, and maybe early 4 for regenerative medicine. Here's another good picture of what the knee looks like. This blue right here, again, is the articular cartilage. This is the meniscus, and as we see as we get older, so you see these bone spurs that start forming, and then we start seeing cartilage loss, and this is where we start seeing, like, you can start seeing a deformed knee, could start seeing cartilage or bone on bone pain happening. So this is a pretty banged up knee. All right. Some more pictures on x-ray. Here we're seeing grade 0. This is a good knee, nice joint space that we're seeing over here. Grade 1. And then as we come to grade 2, we can actually see there's a little bit less space. Grade 3, we're definitely seeing more bone on bone, especially right in the middle. And right over here, and then it's grade 4 that it just looks like almost like one bone. Grade 4 is definitely the severe degeneration. And so, like I said, grade 2 and grade 3 is really where we want to step in, and possibly early grade 4. Okay. Once again, last picture on the x-ray about this. So normal joint space here, we can see that this is a normal space, and then this is the loss of joint space. So when you're going up and down stairs, that's even more painful, or running or speed walking, any of this is where the bone hits the bone. Okay, so that's our arthritis. Okay. Another thing which we always have to be wary about is poor gait caused by pain. So when your hip or your foot is injured, the way you walk can change, your gait changes. That change in your gait may actually worsen your knee pain. So my father experienced something like this himself, where he actually had ankle pain, and he kept telling me his ankle is hurting, and got an MRI and x-ray, and his ankle was completely normal. All the images were normal, but it was actually his knee that was completely shot and had severe arthritis. And so same way you could have severe knee pain, which can present as ankle pain or hip pain. It's usually the affected joint and then a joint above and a joint below that get affected. So let's say if your knee hurts or you have severe knee arthritis, you'll also oftentimes get ankle pain and hip pain, because that's your joint above, which is the hip, and the joint below, which is the ankle. ACL injuries. ACL injuries are also something that we can treat with regenerative medicine. ACL is a strong ligament that basically connects the two bones together. That's the top one is the femur, the lower one is the tibia, and this is often seen in like tennis injuries or in football injuries, often in, and this is something that PRP and bone marrow works very well in. Patella tendinitis. Patella tendinitis is a common overuse injury. It's often seen in runners, and it causes pain right below your kneecap. So if you put your finger right below your kneecap, and you kind of follow it down, that's the patella, and stress in there causes tiny tears in those tendons. Those tendons, if left untreated, then they often they lose that elasticity, they lose the nice motion that they're given, and then from these micro tears, they can become larger tears. So by fixing them when they're smaller, especially with PRP, they do very, very well. A torn meniscus. I'm sure everyone's heard about medial and lateral meniscus, and these are on the sides of the knees. And a torn meniscus can result when you forcefully twist or rotate your knee. There's two kinds of meniscus injuries. One is usually when we're doing an activity, which is a pivoting, a sudden stop and turn, or kneeling. Sometimes it can also happen as we just get older and the arthritis gets much worse, and as we talked about and saw those bony spurs, the bones can then go and start degenerating and pressing on the meniscus and causing degenerative meniscus changes. This works very well with bone marrow injuries. Bone marrow aspirate concentrate works very well to fix these, and actually we see after 6 months changes on the MRI. So where there was a tear, now that tear is gone. So let's talk a little bit about non-surgical treatments for knee pain and what I do in the office. So the first and foremost thing is simple joint injections. They're injections into the knee. I do all my injections under ultrasound guidance, just so that I make sure that everything goes in the right place. They actually did a study where they compared doctors that do them blindly, that's without any guidance, versus when they do them with guidance. With guidance, there's 100% accuracy, and without guidance, there was about a 68% accuracy. So I think always ask if your doctor is using any form of guidance. That could be ultrasound guidance, or it can be fluoroscopic guidance. So two kinds of injections. If you come into my office or in any doctor's office with a flared up, swollen knee, severe knee pain, can't bend, can't twist, feel like you have water in your knee, then more than likely you're going to get a cortisone shot. They're going to drain the fluid out of your knee, or at least I would drain the fluid out of your knee and give you an injection of cortisone so that you can be functional and at least, get back to walking without some pain. And then possibly in a week or so, consider hyaluronic acid injections. Now, hyaluronic acid is the same thing. I'm sure we're all familiar with fillers, and you do any kind of fillers in your knee, in your cheeks or lips or anything. I call this the filler for the knee. So here in the first picture there's degradation of the cartilage, there's narrow joint space, and then the second picture with the blue in the middle in D, we can see that area is filled in, and that's filled in with hyaluronic acid. So it acts like a cushion for the knee. It's usually done once a week over the course of 3 weeks. Insurance will pay for it every 6 months. Most insurances do. And it's a great way to, I almost call it like a vitamin for your knee. It's a great way to keep your joint lubricated so that, and this is something that I recommend, that if anyone has mild to moderate arthritis, they should just do that every 6 months, because it's a way to just keep things under somewhat of control. All right. Here I'm doing a PRP. So what is PRP? Let's just talk about that first. So PRP is the process of taking your blood right out of your own vein, spinning that blood, and then injecting that. After you spin it, taking out the platelets, and the platelets are the growth factors. Blood is usually divided into red blood cells, white blood cells, and platelets. So it's basically taking the platelets out of there and then injecting those platelets, which have growth factors in them, into your injured joint. Those growth factors then cause a healing response. So PRP is not stem cell therapy, and anyone that tells you that it is, I would ask you to be careful and aware. PRP contains growth factors and proteins, and it stimulates your body's healing properties and repairs damaged tissues. So here is
numb the knee. How you doing? I'm good.
Injecting. We always use cold spray, numbing a little bit, and then we inject the PRP. So the PRP is this yellow fluid, often known as liquid gold. And
now we're going to add the PRP into the knee joint.
We're injecting it right into this patient. Had mild to moderate knee arthritis. We're checking under ultrasound, making sure we're going into the right space.
How you doing?
So we're just pushing the knee in, and we're good. So the next, sorry about that. the next thing, so this, now we're going into the world of regenerative medicine, more deeper into that world. So the first stop is PRP, where we're taking the blood. Now we're taking it a step further, and we're actually going into your fat. So this is probably everyone's favorite procedure when we talk about it. We take out the fat, often taken out right from your stomach. We take the fat out of your stomach, and this fat actually has the highest amount of stem cells in our body compared to anywhere else. So we take the fat out of your stomach, or the adipose. We spin it, centrifuge it, and micronize it, or make it small, activate the stem cells, and then inject it into your knee. Patients do very well. There's no anesthesia. It's all done within the office. Takes about 2 hours from start to finish. The area is numbed in your stomach, so it's some mild discomfort, but it really doesn't hurt. And once the fat comes out, it's permanent fat removal, and then we inject that into your knee. We had a patient, actually we're gonna hear about her.
I could not walk down subway steps. I would need to hold on to the rail. Every step I had, it killed my knees. I had to be very ginger. And here we are in New York, and I'm a subway girl. I found out about the doctor, and I am so thrilled I did. I was her second patient that started this process on the journey I'm on. And we removed some fat from my stomach and blood. We mixed the formula. I was vivid throughout the whole process, watched the team work on me and go through the process, and my life changed. I was able to get back to not doing boot camps again. I had to adjust my lifestyle, but I was able to walk up and down subway steps, walk through Manhattan, not a problem. Modified my workout regimen since I am very much a gym rat. Was able to do yoga, let the teachers know that I would be modifying, able to do Pilates, which has really helped me and keep my strength and my stability up. I would recommend this to anybody that is the way I was when they couldn't walk up and down steps. And I feel that this is going to be a way of life for me on this journey, as long as I continue with my maintenance and going through the MRIs to see the progression of my knees. And I couldn't be happier with the team that's in place here, and I'm happy that I'm able to walk again.
Great. All right, so that was our patient Iris. Let's go on to our next. So the next and final stop here is BMAC, or bone marrow aspirate concentrate. So this is probably the most common and well-known way of extracting stem cells. This is the same thing when someone has a cancer, when we take out bone marrow, and it's the same stem cells that we use to regenerate or to fix leukemias. This is now used for orthopedics. So total nucleated stem cells, which are the stem cells which come out of the bone marrow, are the gold standard for any kind of cartilage loss, any kind of meniscus tear, and also often they're now being used for low back pain and disc herniations, rotator cuff tears, larger tears, and Achilles tears. So basically here, we're going to go forward here. Here's a nice picture. This is actually one of my favorite pictures. This is really showing you, this is an MRI picture. And here's the femur, and below is the tibia. So now here what we can see is this white thing right here on picture A, where the arrow is pointed, is bone marrow edema. And this is when when your arthritis is so bad that the bone is hitting the bone, and it's almost like a bone bruise. Now this picture B is taken 6 months later on the MRI, and we can actually see that it's healed. So bone marrow aspirate concentrate is more for severe cases. I would say probably grade 3 and early grade 4 knee arthritis. We every case we've done so far in our office, we've had at least 70 to 80% improvement on our patients. We've been tracking them and following them. Here we're going to talk to, here's our lovely patient. We're going to listen to our patient, Chris. Chris actually came to me with, he had seen a previous doctor, had a PRP done. It wasn't really done under any ultrasound guidance. He was not happy with the care. He came and we talked about how his condition, he had a large cartilage loss and was recommended surgery, and I told him to consider bone marrow therapy before trying to do surgery. So here we're gonna listen to Chris, and then we're actually gonna see where Chris is at now. Now remember, when Chris saw me, he was not able to go to the gym, not even able to run. So we're gonna hear what he says. Christopher. Hi. Chris had bone marrow done about 12 weeks ago in both his knees and in his shoulder. Chris, tell us how you were doing prior to your procedure.
I was a mess. So my left knee was like, the cartilage was like completely gone. It was a little bit bad in my right knee, but not so much. And then my right elbow was totally in pain. The stem cell, my knee is considerably better. Like now I can do different things that I wasn't doing before, squats and what have you. My right knee is like 100%, and even my shoulder is definitely 100%. Like, it's a miracle. It's like miraculous. I highly recommend it.
All right, and now we're going to see Chris in action. This is much against my advice, but he did it anyways. You can see how he's lifting his heavy weight on his knees, and this is a guy that couldn't even run a little bit and walked about 5 blocks and had pain. So there we go. So just in conclusion, there's many types of injuries and conditions that can cause knee pain. Surgery is not the only solution. You do have options: PT, chiropractic, medication, simple procedures like joint injections. Not everyone needs to have regenerative medicine or PRP or bone marrow, but I just want everyone to just take a breath between PT and getting surgery and just think and see if all the other options are there. See a physiatrist, a sports medicine doctor, see your other options. And you don't have to live with knee pain or go through surgery to get rid of it. And finally, we're just going to conclude before we start our Q&A of, here's our patient Desiree. Remember we talked about her? She was not able to walk up and down, and now look at her. She's not holding the handrail or anything. There we go.